Good afternoon. Hello, and thank you for joining the Pituitary Networks Association's webinar program. The PNA is a nonprofit organization that relies on the support of our members and donors. We offer this webinar series to help educate patients, their families, and their healthcare providers. During the webinar, feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Any questions that are not answered will be reserved and answered by email. Our presenter today is Dr. Kevin Ewan, and the webinar is titled Diagnosis, Treatment, and Safety of Growth Hormone Therapy in Adults. Dr. Ewan completed his fellowship training in internal medicine and endocrinology at the University of Cambridge, United Kingdom. For his MD thesis, he also spent an additional 5 years at the University of Cambridge studying the effects of low doses of growth hormone treatment on insulin resistance in hypopituitary adults with growth hormone deficiency and subjects with metabolic syndrome. Due to his interest in pituitary diseases and insulin resistance, Dr. Ewan focuses his clinical practice on the diagnosis and treatment of pituitary and adrenal tumors, pituitary dysfunction, with a particular interest in growth hormone deficiency and excess hypogonadism and cortisol deficiency and excess. Dr. Ewan is well known nationally and internationally in the field of pituitary research, conducting many growth hormone dosing and diagnostic studies, and growth hormone secretion and long-acting growth hormone preparation studies in the diagnosis and treatments of adults with growth hormone deficiency, respectively. Dr. Ewan has published extensively and authored several book chapters in the field of pituitary and diabetes. Now please let me introduce Dr. Ewan. Hi, Dr. Ewan, you're on.
Thank you very much for the kind introduction, and thank you for coming in and listening to my presentation today. And I would like to express my gratitude to the Pituitary Network Association for inviting me to present my talk today entitled The Diagnosis, Treatment, and Safety of Growth Hormone Therapy in Adults. So briefly, what I would like to do is to highlight the objectives of my talk, and I have broken it down to 5 different components. Firstly, I think it's important to understand the physiology of how growth hormone is controlled and regulated and produced in the body. So the understanding of growth hormone physiology and action is important. And then I'll then go on to talk a little bit about the clinical features of adult growth hormone deficiency syndrome, things to look out for in a patient with adult growth hormone deficiency, and then followed by how one would diagnose this condition in a patient, followed by the current approaches of treatment in adults with growth hormone deficiency, and then finally to review briefly the safety profile of growth hormone replacement, given the fact that growth hormone is a treatment that is ongoing for many years, and therefore the safety aspects of it is something that is of paramount importance too in these patients who are injecting themselves with growth hormone therapy for a long period of time. So this slide essentially shows you the physiology of the growth hormone abbreviated GH and IGF-1, which is the insulin-like growth factor 1 axis. Growth hormone and IGF-1 is very closely interlinked, and as you can see in this slide here, growth hormone is produced, or shall I say is regulated in the hypothalamus in the brain by 2 other hormones, namely the growth hormone releasing hormone, which stimulates growth hormone production from the anterior pituitary, and the somatostatin, which somewhat controls and tonically inhibits growth hormone production, so that growth hormone production from the pituitary is produced in a controlled manner. And as you can see here in this slide, growth hormone is produced and regulates many parts of the body, namely the bone, where it has both growth hormone and IGF-1 actions, the fat cells, the muscle cells, and also the liver. Now, it is important to be aware that the liver is where IGF-1 is mainly produced and is regulated by growth hormone production. Therefore, when IGF-1 is secreted from the liver, it engages itself in what we call a negative feedback mechanism to tell the brain that how much growth hormone should be produced or how much growth hormone should not be produced, so that the levels of growth hormone is maintained in a constant fashion, and that so that the body is not exposed to too much or too little growth hormone at any given time. So this is a slide to show you how growth hormone is produced over 24 hours in a day. And as you can see here, the growth hormone is produced in a pulsatile fashion. There are, on average, about 7 to 9 large pulses that are produced during the 24-hour period. And so in this slide here, you can see that the pulsatile secretion of the growth hormone is in a 30-year-old adult. And if you compare that in red, which is the pulsatility or the pulse pattern of a 60-year-old adult, you can see that the pulses remain essentially very similar, except that the difference is that the peaks of each pulse is obviously somewhat much lower in the 60-year-old compared to the 30-year-old. And this is not surprising because physiologically, as we get older, growth hormone production declines, and this is explained by the reduction in growth hormone production as one gets older. So the next question is, well, what is the adult growth hormone deficiency syndrome, and why do we need to treat it? Given that, as many of you are aware, that growth hormone is primarily responsible for growth. So why does an adult have growth hormone deficiency? Well, as you can see here in this slide, there are many features that characterize the adult growth hormone deficiency syndrome, namely the reduction in somatic development. Somatic development means that essentially the growth is somewhat reduced in adults, and the development is somewhat reduced in adults. You can also see that there is also a significant reduction in bone mineral density that predisposes these patients to osteoporosis in later life, a reduction in lean body mass, and an increase in fat mass. There's also a reduction in muscle strength and cardiac capacity. Glucose intolerance is also a prominent feature. So is hyperlipidemia, or what we call abnormal cholesterol and lipid profile. There's also a huge component of psychosocial issues in these patients, namely low confidence, low self-esteem, predisposition to depression and increased fatigue, social isolation, and impaired cognitive function and abstract thinking. So all these are very important features that predisposes these patients to an impaired quality of life if these patients are not treated. Now, how big is the problem? And this slide emphasizes the scale of the problem that we see here in the United States. And these are data that is derived from the Centers for Disease Control and Prevention, the CDC as we call it. And it's estimated that in the US alone, the incidence is approximately 50,000, although I suspect that this number is perhaps an underrepresentation of the true figure, because there is still a lot of patients out there that are yet to be diagnosed with this condition. There is also a projected estimate of almost 6,000 new cases diagnosed a year, and this figure is gradually increasing, and I'll explain this in a little bit more detail why I say so. The suggested incidence of this condition resulting from pituitary tumors, which is the major cause of adult growth hormone deficiency, is approximately 10 person or people per million annually. And it's also estimated that about 15% of patients who are diagnosed with a traumatic brain injury or TBI per year will have underlying growth hormone deficiency that is eventually diagnosed further down the line as they are being worked up upon. There are also other causes that are now increasingly recognized. Subarachnoid hemorrhage is one of them, which again is a condition that tends to occur in elderly individuals and can range from between 6 to 10 individuals per 100,000 population per year. And of that figure, almost a quarter of them will be diagnosed with adult growth hormone deficiency. So I'm kind of want to apologize, this slide is a little busy, but importantly I wanted to emphasize the point that if patients with or shall I say adults with growth hormone deficiency, they're not treated, they have an increased risk of mortality and morbidity. So on your left side here, you can see here is a slide of mortality in a population in Denmark of almost 1,800 patients suffering from adult growth hormone deficiency, and they compared that with just over 8,000 control subjects. And what they found is that patients with who are males who develop growth hormone deficiency during their childhood and females alike, as you can see, the darker line here represents an increased mortality in both genders, be it childhood onset patients, and similarly in adult onset patients, both males and females. Again, similar picture is seen where the mortality is increased as well. The question then becomes, well, what causes these patients to have an increased mortality? And this slide here gives us a clue as to potentially why that is. The causes of increased mortality may be related to endocrine causes, lung problems, genital problems, neurological diseases, diseases of the eye, ear, and circulation, and also head traumas. So the increased morbidity of these patients is largely due to a variety of disorders, of which some of it can be readily explained by its effects in causing growth hormone deficiency. Now, the other explanation as to potentially why growth hormone deficient patients have an increase in morbidity and mortality is the fact that they have a higher incidence, a higher prevalence of metabolic syndrome. Metabolic syndrome, as you know, is a syndrome that encompasses high blood sugars, high blood pressure, hypertension, and also predisposition to diabetes and high cholesterol and obesity. And you can see here in this study performed by Johann Verhelst, published 3 years ago, and they looked at several countries in Europe and the US, and what they found was, you can see here, the incidence of metabolic syndrome, which ranges between 15% to almost 60%, which is somewhat higher compared to the normal population, which is almost double compared to the normal population. And this could potentially explain the increased risk of morbidity and mortality in these patients. So, how do we treat or why do we treat patients with growth hormone deficiency? And the reason we treat them is because there are several beneficial effects that can be observed, and this slide shows a summary of that. If you treat patients long enough with who are growth hormone deficient with growth hormone replacement, many studies have consistently shown the improvement in lean body mass and a reduction in fat mass. And this hopefully reduces the risk of cardiovascular disease. Likewise, for the bones as well, if treatment is continued for at least 18 months or more, studies have shown that certainly in both childhood onset growth hormone deficient and adult onset growth hormone deficient patients, bone mineral density tends to improve, and this reduces the risk of osteoporosis, which again is highly prevalent, particularly in women who are postmenopausal. Lipid profile or cholesterol levels also improve, and there's an improvement in the good cholesterol HDL and a reduction in the bad cholesterol LDL with the overall improvement or a reduction in total cholesterol. Aerobic exercise capacity is also improved, as evidenced by many studies showing an improvement in the oxygen consumption of the muscle. And lastly, but not least, quality of life. Again, I mentioned to you earlier, quality of life in these patients are typically impaired, and you can see that if you treat these patients, especially those who at baseline have poor quality of life, many studies have shown a consistent improvement in some aspects of quality of life, which is highly proportional to the degree of impairment at baseline. So this is just another slide to show you a study that was nicely done by Philip Maison, published almost 10 years ago now, looking at many studies of what we call meta-analysis. Meta-analysis means it's a collection of many studies, which then increases the number of patients in the study significantly to improve the power calculations of the study. And you can see here the global effect size, and if you go across this side of the chart, it means that it's worsening. And you can see here the LDL cholesterol, total cholesterol, and diastolic blood pressure, they're all significantly reduced, suggesting that growth hormone actually has positive effects on these parameters, and therefore may have positive effects on improving cardiovascular risk long term. So the question now that we are faced with is, okay, if you see a patient that you think may have growth hormone deficiency, well, which particular types of patients do you tend to focus on who are likely to have growth hormone deficiency? And really, patients who have signs and symptoms of pituitary disease. So these would typically be patients who have undergone pituitary surgery, or patients who have undergone cranial or total body irradiation, patients who have had a history of traumatic brain injury, patients who have genetic pituitary problems. All these types of patients are very high risk to develop growth hormone deficiency in later life. So this slide here shows you the potential causes of growth hormone deficiency in adults. And you can see here, this is a study from the Hypopituitary Control and Complications Study Database of almost 6,000 patients studied in 16 countries in Europe and North America between 1996 and 2005. And they reported that the most common cause of adult growth hormone deficiency is pituitary adenomas. And other causes are also present, include craniopharyngiomas, pituitary hemorrhage, or another name for it is Sheehan's syndrome. And then there's also a group of idiopathic. Idiopathic means unknown causes. Although having said that, more recently we are recognizing that these patients who were originally being classified as unknown, in fact, have had a history of these conditions, particularly head injuries, cranial or total body irradiation, autoimmune diseases, severe blood loss either from motor vehicle accidents or from pregnancy-induced blood loss, subarachnoid hemorrhage, stroke, and any types of infections in the brain, typically like meningitis or viral encephalitis. So now that we have focused our attention to the likely groups of patients who may develop growth hormone deficiency, the question then is, when should we test for adults for growth hormone deficiency? So again, patients who had recently undergone pituitary surgery, cranial or body irradiation, should be tested, but only after other pituitary hormones are tested and adequately replaced. So this is a slide that emphasizes the point of patients who were diagnosed with growth hormone deficiency in childhood. And so as these patients go through to become adults, typically what has happened in the past is that growth hormone treatment is discontinued as they reach final height. And once the treatment is discontinued, the guidelines recommend that the discontinuation of growth hormone should be at least for a month, and then after that, these patients should be retested for the possibility of growth hormone deficiency. Indeed, patients who have very, very low IGF-1 levels are very likely to develop growth hormone deficiency, but nevertheless, all patients should be retested after stopping growth hormone for at least a month. What about other types of patients who potentially may develop growth hormone deficiency? Well, we have a consensus guidelines that were published about 9 years ago by Enzio Gigo in Italy, and these are patients with traumatic brain injury. So on the left side of this panel, you can see that patients who present with traumatic brain injury in the ICU or in the neurosurgical wards, you could consider hormonal testing, and these patients should be followed up at 3 months and 12 months after being tested, because patients with traumatic brain injury may not necessarily develop pituitary hormone deficiencies or growth hormone deficiencies at the very outset, and sometimes it takes 3 to or sometimes even 12 months before this condition manifests itself. In contrast, if you are seeing a patient with a previous history of more than 12 months of traumatic brain injury, then a thorough history is obviously very important, and you could conceivably perform growth hormone testing around the time that you see them to see if they have growth hormone deficiency or not. So then the question then arises is then, well, if you have decided that you want to test these patients, the question is then, how do we conduct testing in adults with growth hormone deficiency? Two major points. One is you measure their serum IGF-1 level, and the other test is, once you've measured their serum IGF-1 level, and if they are low or if they are low normal, and you have a high suspicion they have growth hormone deficiency, you would then proceed with 1 or sometimes 2 growth hormone stimulation tests. Now, talking about IGF-1, it's important to appreciate the fact that patients or IGF-1 levels throughout life tends to decrease just like growth hormone. Remember, I mentioned earlier, growth hormone regulates IGF-1. So as one ages, IGF-1 levels tends to decrease in both men and women. So when you are measuring IGF-1, you have to make sure that the reference range is appropriate for the patient's age, so that the right value the right IGF-1 value is appropriate for the patient's age. IGF-1 assays are also variable from assay to assay, and that's also another potential issue here. So you have to make sure that you know the assay, the lab you're sending the blood test to see if they provide you an age-related IGF-1 reference range. Other factors that may affect low IGF-1 include poor nutrition. So if the patient has not eaten for a day, or having have anorexia and things like that, they could have excessively low IGF-1, and that does not mean they have growth hormone deficiency. Patients with poorly controlled diabetes, particularly those with type 1 diabetes, because the generation of IGF-1 by growth hormone in the liver requires insulin, and if patients, particularly those with type 1 diabetes with inadequate insulinization, they tend to have low IGF-1s as well. That doesn't mean these patients have growth hormone deficiency. Patients with untreated hypothyroidism also may have potentially low IGF-1, so is patients with liver failure, liver disease, kidney failure, and also an emerging group that we're seeing more and more is patients with sleep disorders such as those with fibromyalgia, which, as I said earlier, growth hormone is regulated by sleep, and if you have a sleep disorder such as fibromyalgia, that can also affect IGF-1 levels as well. So, how do you diagnose adults with growth hormone deficiency? And there are actually three organizations that have published their consensus guidelines: the Growth Hormone Research Society, the American Association of Clinical Endocrinologists, and the Endocrine Society. And essentially, in summary, all of these societies recommend that in order to confirm that these patients have, whether the patient has growth hormone deficiency or not, they need to undergo a growth hormone stimulation test. And here, in this table here, they give examples of the various tests that one can use to confirm the diagnosis of growth hormone deficiency in adults. And then once the diagnosis is confirmed, then the growth hormone dosing is based on the IGF-1 titration to achieve normalization of IGF-1. And more recently, in 2009, this is the ACE guidelines that has been updated. And again, the same thing, basically saying that if you have suspected growth hormone deficiency or possible growth hormone deficiency, insulin tolerance test is the widely accepted gold standard test to use to diagnose growth hormone deficiency. But one can also use other tests such as the glucagon or the arginine. Okay. So here's a table here that shows that the comparison of different growth hormone stimulation tests. And as you can see here, I've listed down here how these different tests are done. And you can see that for the insulin tolerance test, is basically giving insulin intravenously 0.1 units per kilogram, and then measuring glucose, growth hormone, and cortisol. The advantage of this test is the fact that one can simultaneously assess the hypothalamic pituitary adrenal axis in these patients, but the major disadvantage is the fact that you're lowering blood sugars in these patients, so there is a high risk of potential side effects, which could be dangerous, especially in patients who have a tendency to have epilepsy or low blood sugars or heart disease. So this test is not a test that one can use for every patient, and it has to be patient selective. At one point, we tended to use the growth hormone releasing hormone arginine test, but unfortunately, this test is no longer available in the United States, but I'm aware that it's remains available in certain parts of Europe. So that's the reason why I've listed it down here. This test was a very convenient test to perform because most patients are able to tolerate it very well, but unfortunately it's no longer available here in the US. And as a result, we have tended to use the glucagon stimulation test, which is administering glucagon 1 milligram intramuscularly or subcutaneously, and then measuring glucose and growth hormone at baseline and every 30 minutes for 3 to 4 hours. Main side effect for this test is nausea and vomiting. And below here you have also other potential agents that one can use to perform the growth hormone stimulation test, such as ghrelin and ghrelin mimetics. Unfortunately, again, these agents are not available here in the US. They are available in some parts of the world, but not in the US. So I'm not going to spend a lot of time talking about that. Okay, so this is basically just to show you that in 2008, growth hormone releasing hormone was discontinued, hence in the US, and that was the reason why it was not available, and the growth hormone releasing hormone arginine test was disbanded as a result. And like I showed you earlier, there are a number of other tests agents that one can use, but again, all these agents are available in some parts of the world but not available in the United States. So the glucagon stimulation test is now gaining wide recognition and increasing popularity being used here in the US, and I know it's been used quite frequently in Europe as well, and basically it's based on these two studies showing that the glucagon is able to distinguish patients from control subjects, and at a peak growth hormone level of 3 gives you the best sensitivity and specificity in order to diagnose growth hormone deficiency. So once you've decided on treating patients, treating a patient with growth hormone, then the question is, how do you dose them? And I'd like to provide several case scenarios to help illustrate the point. Firstly, this is a patient of 26-year-old patient with growth hormone deficiency due to a non-functioning adenoma who was taking birth control pills. And as you know, birth control pills contains estrogen, high levels of estrogen. So when a patient is taking is taking birth control pills and has high levels of estrogen, estrogen can actually impair the action of growth hormone, and therefore higher doses of growth hormone are required in order to achieve the normalization of IGF-1. So here what happened to this patient is, after stopping growth hormone, you can see with the same dose the IGF-1 shot up quite significantly because of the fact that the patient had stopped it. So by lowering the dose, we were able to normalize the IGF-1 levels back to the normal range. So this really highlights the point that growth hormone action is really dependent on estrogen. So this is a study performed by my mentor David Cook back in 1999, showing that women without oral estrogen and women with oral estrogen and men, you can see that in order to achieve comparable levels of IGF-1, the doses here of growth hormone is almost double. So meaning, in other words, when a woman is taking oral estrogen, more often than not, one has to double the dose of growth hormone in order to achieve comparable IGF-1 levels. Again, reiterating the point that growth hormone action is affected by oral estrogen. And so this is another patient, from the same study again, So again, highlighting the point that this patient was on oral estrogen, and then when the patient stopped oral estrogen and switched over to transdermal estrogen, you can see that the patient developed muscle and joint pains because at that point she was overdosed. So by lowering the dose, IGF-1 normalized the symptoms of muscle and joint pains, then resolved by itself. So general rule is if a patient is on oral estrogen is to start and then when the oral estrogen is stopped, then the general rule is that one should be aware that one should reduce the growth hormone dose by 40 or 50% at least, and patients who stop transdermal estrogens typically one should consider reducing the dose of growth hormone by about 30 to 40%, just to make sure that these patients do not develop side effects. So the second case is a 36-year-old woman with Sheehan syndrome, which is basically a blood loss from pregnancy causing growth hormone deficiency in the pituitary gland. And this patient has a previous history of diabetes during pregnancy and was also gaining weight following the pregnancy. And when she was found to have growth hormone deficiency based on the insulin tolerance test, where her growth hormone peak was only 0.2 and a low IGF-1, she was put on growth hormone replacement. And as you can see in this table here, she was predisposed to diabetes to begin with because she had a previous history of diabetes in pregnancy. And when she was put on growth hormone, you can see at these doses the fasting glucose levels continued to rise, and also the patient's hemoglobin A1C was also gradually going up, indicating that high doses of growth hormone replacement can actually aggravate blood sugars, and sometimes in a person who is susceptible to diabetes, it can actually push them to develop diabetes along the way. And this study basically confirms what I've just been telling you. This study is basically a 30-month study looking at patients with severe growth hormone deficiency, and what they did was they gave them oral glucose tolerance tests, and you can see before growth hormone or baseline, if you like, these are the blood glucose levels, and 30 months after getting growth hormone, you can see that the glucose levels were much higher, indicating that they had deterioration in their glucose following high doses of growth hormone. And this is confirmed by the fact that they had higher insulin levels and higher C-peptide levels. However, on the flip side, if you use low doses of growth hormone, and this is a study that I performed almost 9 years ago now, where I gave patients a very low dose, 0.1 milligrams fixed dose, did not change the dose, compared that with patients on standard growth hormone dosing, which is on average 0.5 or 0.6. And what we found is that very low doses of growth hormone can in fact do the opposite, which is they can actually improve or lower blood sugars. And this is the lowering of blood sugars continue as long as the patient was put on low doses of growth hormone, not the high or standard doses. And when we did insulin clamp studies, basically this is a clamp study to ascertain if the patient has insulin, the degree of insulin sensitivity, and you can see that the low dose group had much higher insulin sensitivity, suggesting that there was an improvement in glucose tolerance and insulin sensitivity when low doses of growth hormone are used. And we think this may be related to the fact that low doses of growth hormone actually increases IGF-1, or if you like, insulin-like growth factor 1, which has insulin properties, and that is the reason why it is it is possible that the increase in bioactive IGF-1 by the low doses could improve blood sugars in these patients. So, in summary, for patients with potential glucose problems, obviously do not forget to encourage weight reduction in these patients. This applies to every patient, not only those with growth hormone deficiency. Perhaps consider starting with low doses of growth hormone. If patients are already on growth hormone and you see that their glucose is worsening, you could consider lowering their doses by 30 to 50%. And anticipate susceptible patients with potential glucose problems, particularly those who are overweight or obese, or those with a strong family history, or indeed those who have had a previous history of diabetes during pregnancy. And if patients who already have diabetes, it is also important not to forget to adjust these diabetic medications accordingly when growth hormone replacement therapy is instituted. So this is a third case, and essentially this is a patient who has a 17-year-old woman with isolated growth hormone deficiency with abdominal fat after the fact that she has stopped growth hormone for 8 months. And remember, I told you that patients with growth hormone deficiency tend to gain weight, particularly in the central region, and this lady exemplifies that. And after stopping growth hormone for 8 months, her fat, as assessed by the DEXA scan, was increased. So we resumed the growth hormone replacement in her, and as you can see here, the body fat had actually decreased by almost 50% when growth hormone was resumed in her. Very good results here, as you can see. And patient was able to resume her dancing lessons, and there was no side effects. Typically, side effects tend to be very rare in younger patients as well. And then finally, in the fourth case, is a patient with who was already on low-dose hydrocortisone, which is a steroid hormone. Particularly, these are patients who, particularly pituitary patients who have also low cortisol, so they are put on low-dose hydrocortisone. And on a very low dose of hydrocortisone, 5 milligrams twice a day, was given low-dose growth hormone. And indeed, after starting growth hormone, the patient became more tired and more unwell, and was in fact admitted to the ER with nausea, vomiting, dizziness. And it turns out that what happened was that this patient's cortisol level had actually decreased substantially after starting growth hormone. And this is indeed a phenomenon that that is important to be aware of. And what usually happens is when you increase the dose of hydrocortisone in these patients, they generally feel better. And the reason is because there is an enzyme called 11-beta-HSD1 that growth hormone inhibits. So if you put a patient on growth hormone, just be cognizant of the fact that you may have to increase the dose of hydrocortisone if the patient is on hydrocortisone, to avoid pushing them into potential adrenal crisis, because growth hormone can suppress this enzyme here and therefore reduce the conversion of hydrocortisone to cortisol, which is the active portion of the cortisol molecule. And this is just a slide to show you that different doses of growth hormone can actually inhibit this enzyme, even up to doses of 0.5. So one has to be a little more, more aware of the fact that this is a potential possibility, and may need to increase the dose of hydrocortisone if the patient is already on hydrocortisone. So, in summary, factors that can affect growth hormone dosing is that you can increase the dose, particularly if the patient is started on estrogen, or if they're changing from patches to oral estrogen. And increasing the dose can potentially increase lipolysis, which is fat breakdown, and also potentially can improve quality of life. But one has to also consider decreasing the dose if there are changes, particularly if patients are stopping estrogen, or if they're changing their preparation from oral to patches, or even coming off patches completely, or in certain circumstances if the blood sugars are worsening. Pregnancy and elderly, you have to reduce the dose, and in fact in pregnancy there's no data of growth hormone use in pregnancy, so in fact you may even have to stop growth hormone during pregnancy. If they develop side effects, then you also need to consider stopping or reducing the dose of growth hormone, such as muscle and joint pains. And finally, very important, consider increasing the glucocorticoid doses, especially when patients are on small doses of glucocorticoids. Importantly is try and maintain IGF-1 within the upper half of the normal range, and also in addition to IGF-1, consider body composition and glucose levels and quality of life as your guide when you're using growth hormone and titrating the doses. Be aware of changing IGF-1 assays, like I had alluded to earlier, by a laboratory, because that can change the reference range. Okay, I'm just going to skip this slide and briefly in 5 minutes talk a little bit about the safety profile of growth hormone. So the question is, once you put a patient on growth hormone, the question is, does growth hormone cause further tumor growth, particularly in patients who already have a pituitary tumor? So this study is designed to try and answer that question. So they looked at patients with non-functioning pituitary adenomas that were either treated with growth hormone and those who are not treated with growth hormone. The median observation time was about 10 years, and what they found is that there was no tumor progression in 74% of patients who were growth hormone treated and 68% of patients who were not treated, indicating that growth hormone treatment does not appear to induce tumor progression, which is obviously very reassuring. This group also did the same study in patients with craniopharyngiomas, and they also found the same result, that is, there was no increase in tumor progression in those treated with growth hormone versus those who were not treated. So this data is indeed very reassuring. What about cancers? So this is the only study examining cancers. And the question that was asked is, does growth hormone induce cancers in patients? And they followed these patients up for almost 4 years, and what they found was that there was no increase in the standardized incidence rate, or SIR here. So basically here, as you can see here, a 0.88, which is less than 1, indicates that there is no increment in terms of cancer risk. And they also continued to look at patients who were treated versus those who were not treated, and again you can see here the standardized incidence rate for both groups were very comparable, suggesting that cancers was not something that was seen following at least 4 years of treatment of growth hormone. Again, very reassuring data. What about deaths, cancer, and other tumors? Again, this is a study that looked at a large number of patients, almost 2,000 patients, and what they found was that after a follow-up of almost 2.3 years in growth hormone deficient adults, they did not find any evidence that growth hormone treatment had any effects on those who were treated versus those who were not treated, in terms of deaths, in terms of cancer, or in terms of other tumors apart from pituitary tumors, suggesting that, again, growth hormone was very safe and did not cause any changes compared to those who were not treated. So although having said that, the follow-up period for this study was only 2.3 years, so pretty short, but then nevertheless very reassuring information. And then finally, this is one of the largest studies that was performed, published 2 years ago, looking at the mortality of patients treated with growth hormone replacement. So almost 14,000 patients, 70,000 patient years. And what you can see is there appears to be an excess mortality in patients who are younger, but as one tends to get older, the mortality rate was comparable to the background population. And if you look closely, you see that the group of patients that had underlying pituitary adenomas, there was no increase in terms of mortality. So this line here, if you exceed 1, there was an increased risk. But as you can see here, for those with pituitary adenomas, which makes up the largest proportion of patients with growth hormone deficiency, there was no increased risk. And if anything, you can see here patients with previous Cushing's disease, craniopharyngiomas, or aggressive tumors, or patients who have had transcranial surgeries and radiotherapies, these were patients who had an increased risk of mortality, which is again not surprising because these tumors were, were more aggressive compared to those who had pituitary adenomas. So, in conclusion, adult growth hormone deficiency syndrome is associated with a cluster of negative effects, particularly on the cardiovascular system, also has negative effects on quality of life, and can potentially increase morbidity or mortality. And we know that from data that I've shown you that growth hormone replacement in these patients does have numerous benefits that has been demonstrated in many studies. The diagnosis requires careful clinical judgment, and once you have a high suspicion the patient has growth hormone deficiency, you would then measure IGF-1 levels using appropriate reference ranges, and then consider confirming the diagnosis with an appropriate growth hormone stimulation test. Growth hormone replacement also should be individualized based on each individual patient's circumstance, and the dosing also should be individualized to avoid inducing adverse events and side effects. In addition, large doses of growth hormone can actually cause worsening of glucose or blood sugars, and therefore in patients who are at risk of developing diabetes, it is important to make sure that low doses of growth hormone are used, and to also advise the patient that this may be something that they may encounter and they may need to increase their anti-diabetic medications. Indeed, if the patient has active cancer, malignancy or active cancer, growth hormone therapy is contraindicated and it should not be used. And finally, from the data that we have so far, there does not appear to be any evidence that growth hormone causes an increased risk of cancers or an increased risk of tumor recurrence in patients with underlying tumors. And with that, I thank you for your attention.
Thank you so much, Dr. Yuan. Very, very interesting. It's just so much information, hard to grasp it all. Okay, so our first question here is, what is considered safe IGF-1 level, which is above the hospital range, when taking GH injections to treat growth hormone deficiency?
Right. So again, when a patient is put on growth hormone, you would measure the IGF-1 levels, and again, IGF-1 levels have to be based on the assay or the reference range that your lab provides you. So I would say that safe levels, meaning and not inducing side effects or worsening of blood glucose, you would aim for IGF-1 levels to be in the middle of the range that is provided, which is age appropriate.
Okay. The next question, we've got quite a few questions, not a lot of time, so a lot of them are going to be done by email, but the patient presents with hemochromatosis. I have increased my IGF-1 from 90 to 130 by engaging testosterone replacement therapy, a significant increase. I routinely get dismissed as having hypopituitarism and GH deficiency because of my TRT inflated IGF-1 levels. I have had 2 failed 4-hour glucagon tests and 24-hour urine using gas chromatography, mass spectrometry, Belgian assay that confirmed growth hormone deficiency. Why is IGF-1 considered as the assay determined growth hormone when 24-hour urine GCMS isolates the growth hormone factor and is substantially more accurate in quantifying the pulsatile activity of the pituitary?
Wow, okay, that's a long question.
Loaded question.
So to diagnose growth hormone deficiency, like I had shown in my earlier slides, IGF-1 is used, but it's used as a screening test, as a marker. But like I said, IGF-1 is not foolproof. So there are potential pitfalls in using IGF-1, and that's the reason why we use IGF-1 to give you a sense of potentially whether or not we should proceed with the growth hormone stimulation test. So testosterone does not play a part in diagnosing growth hormone deficiency. So the fact that the patient has hemochromatosis or liver, which I presume involves the liver, and as you can imagine, IGF-1 comes out from the liver. So you might expect the IGF-1 levels to be low in such situations, and if that's the case, then one might need to proceed with proceeding to a growth hormone stimulation test. And the gold standard test would be an insulin tolerance test to confirm whether or not the patient has growth hormone deficiency or not. And if the ITT refutes the possibility, then it's very hard for one to justify prescribing growth hormone in these patients.
Okay, there's a couple different parts to that question, and I'll ask one more part to this one before I move on. Whole body vibrational therapy is demonstrated at 24 hertz to 30 hertz to stimulate growth hormone output. While the output measures of growth hormone are not stellar, they are measurable. Do you believe there's a potential to use whole body vibrational therapy to stimulate, calibrate, and synchronize the pituitary signal in order to use precursors such as peptides to encourage the natural production of growth hormone?
So there isn't a lot of studies looking at this as far as I'm aware of. I'm not saying that it's not something that could stimulate and equilibrate the pituitary to produce growth hormone. So the literature is still not very clear, and there are not many studies looking at in this aspect. So what we do know is that the only way we can diagnose or confirm growth hormone deficiency is using a growth hormone stimulation test that is well studied and safe in order to be able to diagnose growth hormone deficiency. So potentially, that could be a way to synchronize growth hormone, but there are also a lot of factors that one has to take into account, like age, medications that the patients are taking, which can also suppress growth hormone secretion. So, so the jury is still out. So, short answer to your question is I don't know, and I'm not sure there's any data out there to support that statement.
Okay, yeah, just an interesting idea, though. On the premise that growth hormone replacement therapy stimulates thyroid activity, specifically to T4 to T3 conversion, and limits reverse T3 production, coupled with the premise that both hypopituitarism and hyperpituitarism have profound effects and contributes to the arrhythmia associated with atrial fibrillation. Are you aware of any cases where growth hormone replacement therapy has reinstated the EKG P waves, converted the patient back into normal sinus rhythm atrial fibrillation, or had a profound impact on atrial fibrillation, such as lessening PACs, PVCs, skips, and pauses?
Right. So the fact that growth hormone can actually affect thyroid metabolism has been demonstrated in several studies. However, the effect is actually quite small. So in order, and a lot of these cardiovascular effects such as PVCs, AFibs, requires the effect high doses or high levels of thyroid in susceptible patients. To my knowledge, using growth hormone to rectify that is not something that has been studied or has been published. I wouldn't imagine that using growth hormone would have a strong impact in reversing the heart issues that thyroid levels can actually predispose these patients to, because many of these patients have underlying susceptibility to underlying heart disease anyway. So it might recalibrate the thyroid levels slightly somewhat, but I don't think that it would reverse the heart problems completely. And to my knowledge, I don't think there's any studies that have been done to confirm that as well.
Okay. Okay, please comment on the negative opinion of human growth hormone by primary care and other doctors. When I mention this as a possibility in my treatment, they invariably are negative about this treatment.
Yeah. So unfortunately, growth hormone has had a lot of negative press, partly because of the fact that it has been misused by many many populations, such as athletes, such as for sporting reasons, such as its use for anti-aging purposes, which again, there's no data to suggest that it's beneficial there. So because of that, it has gained kind of a negative press on its usage. So what I tend to tell my patients is that growth hormone deficiency is a true syndrome, and if it is used appropriately, then there's really no reason why it shouldn't be used. It's just that it has received a lot of negative press from a lot of misuse by people who shouldn't be using them.
Okay, yeah, that makes sense. Okay, what about the known CYP450 issues metabolizing both HGH and cortisone for the many who have these issues?
Again, like I showed you in one of my slides in the liver, where the main effect growth hormone has on the cortisol metabolism is actually via the type 1 HSD enzyme, hydroxysteroid dehydrogenase enzyme. To my knowledge, it doesn't have a huge impact on the CYP450 in the liver. So my advice is, if the patient is taking both growth hormone and cortisone, hydrocortisone, then I think it's important to be cognizant of the fact that potentially one might need to increase the dose slightly of hydrocortisone in order to compensate for the potential suppression of the enzyme HSD1. And if you look at, I have many patients who are put on growth hormone who are also on a whole host of other medications that can be affected by this CYP450 pathway. And to my knowledge, I have not seen any growth hormone interactions to those medications that go through that pathway. So, so I think the the main point is to be extremely cautious in such patients and to have a low threshold in asking these patients how they feel, especially to ascertain that they do not have adrenal insufficiency and that they need slightly higher doses of hydrocortisone.
Okay, this is just so interesting. I hate to stop, but we are out of time. So we will answer the remainder of questions by email through Dr. Ewan. And we want to thank you, Dr. Ewan. It was just absolutely fascinating.
Thank you.
This concludes our webinar presentation. If we did not get a chance to answer your question, we will be answering them via email. The PNA wishes to thank you for participating in our webinar. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. Thank you for joining us today and enjoy the rest of your evening. Be sure to watch for next month's webinar and have a very happy and safe holiday.
Thank you.
Thank you, Dr. Ewan.
Thank you. Pleasure.